So if you break an arm or like a leg, an X-ray is basically just a straightforward photograph.
Right, yeah, it's super simple.
You look at the film, you see the jagged white line, and the doctor just points to it. It's clean, it's binary, and honestly, it's kind of comforting.
Oh, absolutely. It gives you a clear answer right away.
But if a surgeon needs to operate inside your face, well, it's a completely different story. They are basically flying blind through this microscopic air-filled cavern system.
Yeah, and that cavern system directly borders your brain and your eyes.
Exactly. So that simple, comforting X-ray machine suddenly really struggles to give a clear picture of what is just a profoundly murky anatomical landscape.
Because the face isn't, a solid block. It is an incredibly complex labyrinth. You're looking at this whole series of hidden, delicate cavities stacked on top of and behind each other.
Yeah.
And understanding the architecture of these spaces isn't just some theoretical exercise in anatomy. When doctors navigate this tiny, hollow space behind your nose, they're essentially trying to defuse a high-stakes anatomical bomb using only grayscale maps.
Which is just wow. And today we are decoding those exact maps. We're pulling from this highly detailed medical lecture via the YouTube channel Global Scale.
Precisely. It's not about the destination of the image. It's about dictating the physical path of the radiation to ensure absolute consistency.
Because if that beam is off by even like a few degrees, the shadows overlap completely differently, right?
Exactly. A shadow might obscure a real pathology, or honestly worse, it might create a false shadow that a doctor then misdiagnoses as a tumor or a fracture.
Man, that is incredibly high stakes. And that logic applies perfectly to the other major views detailed in the lecture too.
Right, like the Caldwell view.
Yeah, the Caldwell view, which is occipitofrontal. So the beam travels from the back of the head straight through to the forehead.
And that projects the frontal sinuses, which are the ones located right above your eyebrows, completely clear of the overlapping skull bone.
And when doctors need to see deeper into the skull, the physical contortions become far more extreme, don't they?
Oh, absolutely. Take the cemento vertical view, for example.
Right, where the patient extends their neck all the way back.
Yeah, all the way back. And the beam shoots from under the chin, the cementum, straight up through the top of the head, the vertex.
Which honestly sounds like a bizarre game of anatomical twister.
It kind of is, but it tracks if you're trying to view the base of the skull.
Yeah, the source notes this specific angle is ideal for visualizing the ethmoid and sphenoid sinuses, since they're buried so deep in the center of the head.
Exactly. There's even an open mouth Waters view.
Wait, they physically shoot the beam through the patient's open mouth.
They do. It's to catch a shadow of the sphenoid sinus without the dense bone of the upper jaw getting in the way.
That is wild. But I guess those extreme angles fundamentally highlight the limitations of the X-ray, right?
They really do.
Yeah.
You are pulling off all these geometric tricks just to see overlapping shadows. And if a patient requires functional endoscopic sinus surgery, or APS.
And that's when a surgeon inserts a tiny camera and instruments into the nose to remove polyps or clear blockages, right?
Yes, exactly. If a patient needs FES, an X-ray simply cannot serve as an adequate map.
I mean, you can't navigate a complex 3D cave system relying solely on a flat 2D shadow of that cave. It's impossible.
Which necessitates a completely different mapping technology. A surgeon absolutely must read a CT scan before performing FES.
It's non-negotiable.
Utterly non-negotiable. You cannot identify a pathology like a carcinoma or a severe polyp without first intimately knowing the normal, healthy anatomical structures of that specific patient.
And the lecture treats reading a CT scan like slicing a loaf of bread, which I found so helpful.
It's a brilliant analogy.
Right, like if you look at the outside of an unsliced loaf, you know it's bread, and you can safely assume there are air bubbles hidden inside somewhere.
But you don't know exactly where they are.
Exactly. But if you take a knife and cut a thin slice, what they call a coronal cut, you can suddenly see the exact layout of every single air pocket in that specific millimeter of the loaf.
And then you cut it horizontally, which is the axial cut, sort of like slicing a hamburger bun.
Yeah, and you gain a completely different perspective of those exact same bubbles.
So by digitally slicing the 3D skull into these ultra-thin cross-sections, the CT scan reveals the four major players we've been discussing.
Right, the frontal sinuses in the forehead, the maxillary sinuses in the cheeks,
The ethmoid sinuses, which sit right between the eyes.
and the sphenoid sinus, which is parked deep in the dead center of the skull.
Right, and the ethmoids seem particularly challenging to navigate based on the lecture.
Yeah, because unlike maxillary sinuses, which are essentially large, empty cavern rooms, the ethmoids are described more as a honeycomb.
A very dense cluster of tiny interconnected air cells.
And navigating a honeycomb requires really precise landmarks. The source zeroes in on one specific bony structure for this,
Yes, the basal lamella of the middle turbinate.
which is a mouthful.
It is, but that landmark is the primary key to orientation in it. The basal lamella is a bony partition that physically separates the anterior ethmoid cells from the posterior ethmoid cells.
So when a surgeon is studying a CT scan, finding that partition tells them exactly how deep they are navigating into the facial structure.
Exactly, it's their anchor point. They also have to locate highly specialized structures, like the Agernacci cells.
And those sit at the very front of the ethmoid honeycomb, right?
Correct. And they also map out the nasolacrimal duct.
Which is that dense bony tube that continuously drains tears from your eyes into your nasal cavity.
Yes, exactly.
So I've been looking at all these microscopic divisions, these ultra-thin slices of bone and air on the scans, and I just have to ask, what does this all mean?
What do you mean?
Like, why the absolute obsession with mapping every single microscopic bubble before going in to just clear out some mucus or inflamed tissue?
Ah, right. Well, the obsession exists because those air pockets are not just empty space. They act as the physical borders to the most vital organs we possess.
Oh, wow.
Yeah. The paranasal sinuses sit adjacent to and are intimately connected with the brain, the eyes, and major blood vessels.
So the stakes are incredibly high.
A surgeon must know the map down to the millimeter because stepping off the designated path during the surgery has immediate catastrophic consequences.
They are essentially scraping diseased tissue away from the literal walls of the brain and the optic nerves.
Exactly.
Well, here's where it gets really interesting and honestly terrifying. The stakes for a surgery that sounds so routine are just astronomical.
They really are. The lecture devotes a massive amount of time to these borders. It specifically warns surgeons about these anatomical danger zones and what happens when the map is misread.
Yeah, Manisha ENT's lecture basically serves as a masterclass in disaster avoidance.
For sure. Let's return to the ethmoid sinuses, that complex honeycomb located directly between the eyes.
Okay.
The ethmoids are separated from the orbit, which is the eye socket, by a structural boundary known as the lamina papyracea.
Right, and breaking down the Latin there, lamina meaning layer and papyracea meaning paper.
A paper-thin bone.
Yeah, the way the source describes it, it's not some sturdy brick wall protecting your eye. It's more like a thin pane of glass trying to hold back a pressurized water pipe.
That's a horrifyingly accurate analogy. If a surgeon misreads their CT map and pushes an instrument just a millimeter too far while clearing out an ethmoid infection, they can effortlessly punch right through that glass.
And the physical mechanics of that breach are just severe.
Yeah, if the lamina papyracea is compromised, the pressure dynamics shift instantly.
The source details how this error leads to an intraorbital hematoma, right?
Yes, which is massive pooling bleeding that gets contained inside the confined space of the eye socket.
Which has nowhere to go.
Exactly. Furthermore, the orbital fat, which cushions the eyeball itself, can physically protrude right through that broken bone into the sinus cavity.
And the cascading effects of that pressure are incredibly grim. If the bleeding and the shifting fat build up enough pressure, it compresses the optic nerve.
And the patient goes permanently blind. All from a routine sinus surgery.
It's just unbelievable. And the borders near the brain are just as perilous, aren't they?
Yes, they are. The roof of the ethmoid sinuses is called the cribriform plate.
Okay.
It basically serves as the ceiling of the nasal cavity, but it simultaneously acts as the physical floor of the brain cavity.
So it's another incredibly delicate sheet of bone,
It is, and it's naturally perforated with tiny holes that allow your olfactory nerves to pass through.
which is what gives you your sense of smell.
Right, but its natural fragility means the surgical margin for error there is virtually zero.
Because if a surgical tool drifts a fraction of an inch too high, it breaches that floor.
And the lecture explicitly warns that this causes a CSF leak.
Cerebrospinal fluid, the specialized liquid that bathes and protects the brain, just begins leaking down into the nose.
Yes, to the patient it just presents as rhinorrhea, like a common runny nose.
But it is actually brain fluid.
Exactly. Opening a direct physical pathway between the non-sterile nasal cavity and the highly sterile environment of the brain creates this express lane for lethal infections.
Like meningitis.
Yes, exactly.
I cannot imagine the psychological pressure of operating millimeters away from the brain using long metal tools inside a dark bleeding cavity.
Well, if we connect this to the bigger picture, it thoroughly explains the intense psychological preparation required for FES.
Because a surgeon doesn't just casually glance at a CT scan, do they?
No, they literally memorize it. They fight the battle in their mind before they ever scrub into the operating room.
Wow.
They have to study those grayscale slices to identify anatomical variations, because human beings are not factory made. We all possess unique structural quirks.
Right. And a perfect example of that quirkiness in human anatomy is something the lecture calls on-a-thigh cells.
Or, more formally, sphenoethmoidal cells.
Right. So normally the honeycomb of the ethmoid sinuses ends cleanly before you reach the deep sphenoid sinus.
But in some individuals, those posterior ethmoid cells grow backward. They expand completely over and around the sphenoid.
And the presence of an anode cell dramatically alters the surgical landscape.
It changes everything because of the sphenoid sinus's terrifyingly important neighbors.
Right, because the sphenoid is flanked by the optic nerve, which is the primary cable transmitting vision.
And the internal carotid artery, which is the massive blood vessel supplying oxygen to the brain.
The source notes that when an anode cell grows backward, it frequently envelops that optic nerve.
Exactly. So a surgeon might believe they are safely working inside a standard ethmoid cell, well away from the danger zone.
But due to this hidden variation, the optic nerve is hovering right in their path, completely exposed.
Yes, and this is compounded by the fact that sphenoid pneumatization,
Which is how the air fills the bone, right?
right, that varies widely across patients too. The lecture notes the cellar type is the most common form of pneumatization.
But regardless of the specific type, those bony walls remain razor thin.
Yes, they do. And injuring the internal carotid artery during an exploration of the sphenoid sinus results in a fatal hemorrhage,
The patient can bleed out on the operating table almost instantly.
almost instantly. Identifying the presence of an anode cell on a CT scan beforehand transforms that image from a simple diagnostic map into a literal survival guide.
It dictates exactly why doctors analyze the precise shade of gray, or why they obsess over whether a specific microscopic air cell is located anterior or posterior to the basal lamella.
The anatomy is a minefield, and the scan is the map of the minds.
Man, we have covered some seriously intense ground today.
We really have.
We started with the physical contortions required for old school 2D shadow puppets. Sending X-ray beams from the occiput to the mentum just to project the maxillary sinuses clear of overlapping bone.
Right, the basics.
And then we moved into the millimeter precise 3D slicing of the CT scan, mapping out the ethmoid honeycombs and the deep sphenoid caves like slices of bread.
Which is when it got really complicated.
Yeah, and finally we navigated the terrifyingly fragile borders of the face, where breaching the peeper-thin lamina papyracea or the cribriform plate can result in permanent blindness or a cerebrospinal fluid leak.
It's a lot to take in.
Next time you have a simple sinus headache, I imagine you'll view the space right behind your nose a bit differently.
No, I do.
It's a perilous, incredibly delicate cavern system, and the preparation required for doctors to operate inside it is just nothing short of extraordinary.
The anatomy is as fascinating as it is precarious.
Yeah.
But, there's one final detail from the source material that really lingers for me.
Oh, what's that?
The lecture briefly mentions the Vidian canal. It is this tiny bony tunnel that transmits the Vidian nerve through the pterygopalatine fossa.
Okay, another mouthful.
Yeah, but it's located right in the vicinity of these sinus cavities we were talking about. And it just forces you to step back and deeply consider the sheer strange logic of human evolution.
Wait, how does the Vidian canal challenge that evolutionary logic?
Well, think about the core biological function of the paranasal sinuses.
Right.
They're essentially empty spaces, likely evolved to lighten the overall weight of the skull and to help humidify the air we breathe.
Makes sense.
But by their very nature, as air-filled pockets connected to the respiratory tract, they are highly susceptible to mundane issues.
Like everyday mucus blockages, minor bacterial infections, or just a common cold.
Exactly. Yet, human anatomy evolved to route our most critical, high-voltage physiological cables right past them.
Like the optic nerve for sight,
The carotid artery for major blood flow.
the Vidian nerve, and the delicate floor of the brain itself.
Yes, all of those directly flank the exact areas most prone to routine infection and swelling.
It's essentially like designing a major city and deciding to run the primary municipal power lines and the high-pressure water mains directly through the walls of the local landfill.
That is an incredibly apt comparison. It is a stunning and somewhat terrifying evolutionary design quirk.
It really is.
We rely entirely on a system where the most vital, life-sustaining structures are separated from everyday infections and surgical interventions by nothing more than a paper-thin layer of bone.
It completely reframes that murky diagnostic landscape we talked about at the very beginning.
It does.
Reading those CT scans isn't just about finding the source of an infection, it's about making absolutely sure you don't accidentally sever the power lines while trying to clean it up.
Right.
We're basically trying to read shadows in a cave where one wrong step brings the entire ceiling down. We'll keep your sinuses clear, everyone. We will catch you on the next deep dive.